folks. Thanks for coming in. This is never an easy group to wrangle after lunch, so we appreciate you coming back. Really excited to kick it off with a couple of good conversations this afternoon. So we are doing this session working together in teams. We have Dr. Claire Bodkin from HAMSMaRT and Marcy McIlveen. And then we also have some great folks from London. We have Sean Warren and Cassidy Morris. So I think we'll just kick it off with HAMSMaRT. They have a little presentation for you guys. And then I think what we'll do is we'll hold for questions at the end, and then so write them down, and then we'll have a lot of dialogue at the end of the presentations.
Thank you, Kourteney. Oh, how do I turn this on? Hello? Is that working? Oh, great. Okay, perfect. Amazing. So yeah, the presentations are, I think, fairly brief, and then we're hoping for more of a chance for us all to talk about ways of working together, either like things we found that have worked really well, or things that we're finding challenging, so we can brainstorm together how we might move through some of those challenges. But we're going to start by just chatting a little bit about our program SASS, which stands for Support and Safe Supply. And it is a partnership between a number of different groups. So the Hamilton Social Medicine Response Team, or HAMSMaRT, who Marcy and I both work as part of. Keeping Six, which is the Hamilton Harm Reduction Action League, the AIDS Network of Hamilton, and then the YWCA of Hamilton, Burlington, Brantford as well. Yeah, so I'm one of the prescribers with the program, and also one of the people who helped us set the program up. And
I don't know if this is on. Can you guys hear me? All right, excellent. I am Marcy McIlveen, program manager now, I guess. Been doing this work for off and on for 2 years, pretty much steady actually for 2 years.
Like, when was the off?
I was not off. Prior to that, I'm just a person that went through some crap with substance use and watched friends die as a direct result of policy and inability to accept people where they're at. Through my own journey, became abstinent, for lack of a better term, and just love people and think it's not about a substance that I put in my body, but what I do with my body and my life that matters. Doesn't matter what I use or what I don't use, it's who I am and who people are, and we need to care more about that than the opposite.
Yeah. Woo-hoo.
I don't know what that was, but thanks. And that's our picture.
Where do I point the clicker?
We're doing great.
Where's the computer? There? All you.
Oh, me.
Yeah,
excellent, I get to talk more.
Wasn't it?
I think so.
Yeah.
So this is our slideshow. If you look at it, it's cool and awesome. Sorry, this is not my forte. I'm more on-gram person. So co-design from the start, or from day one. So prior to SASS starting, another prescriber with us was already supporting people through safer supply or opiate medication. And I don't know who originally came up with the idea of expanding or what it would look like, but
I think it was you.
Okay, I guess me. Again, it's not about substance for me, this whole journey, this whole policy, this overdose crisis, policy crisis, toxic whatever the fuck you want to call it. It's just about people and people not being accepted and people being forced into things, right? Like my own journey, I was forced into rehab 15 times. Or not forced, but when the other option is jail or homelessness, sometimes rehab's good. And I was sick of seeing people just passed off. Here's a prescription, go away, or here's methadone, go away, or here's this, and we'll see you in 2 weeks, and all this shit. And I wanted there to be a way to develop community and develop relationship. And so we talked about what that looks like as a group, and created a place where everybody was of worth, right? My opinion mattered just as valid or as much as prescribers. Obviously there's some differences. I was let's just give everybody everything, and that's not a thing, but which is probably good because it would be crazy. But yeah, it's just collaborating and creating something where it wasn't just about a prescription, and it wasn't just about hanging out with people. It was let's get to know people and give them whatever they need, however we can do that as best we can with what we have, kind of thing.
Mm-hmm. And so we were already working together as a group doing Street Ouch, and when I say we, I mean Keeping Six and HAMSMaRT, and Marcy was the first, well, I guess the second employee, first K6 employee, second HAMSMaRT employee. It was like a shared role as the outreach coordinator. And then we had talked about wanting to expand the Safe Supply program, which Marcy had championed along with some of the other K6 folks. And then Marcy designed the program. I don't know if you want to talk about that, but really I mean, we worked together, but you wrote out the whole program plan and design. And
I guess what we try to do is, again, just give people what they need as best we can, right? So we do peer support instead of case management, where you're seeing an intensive case manager or a social worker or another professional that's gonna have goals for you. We're just how about we hang out and you figure out what you want to do, and we're just gonna walk with you till you get to wherever that is. And if it's really shitty along the way, we'll go through the shit with you, and if it's really good, we'll do really good with you, whatever that is for the person. So some of the stuff, we meet with people, we have conversations, we talk about relationships. The other day I talked about glow kittens, or a few weeks ago I talked about glow kittens.
I don't know
it's a
what those
thing.
are. Okay.
It's supposedly a thing that they made. Some medical research thing made glow kittens. I don't know, look it up. But just letting people be people, and what that looks like. And obviously there's a clinical aspect and prescriptions and stuff, but we go for coffee and we hang out and we spend time and we invite people to come along, whatever that is. We offer peer support training for patients and for people that want to do stuff. You don't have to. Some people don't want to, right? But we offer have that opportunity, or outreach and paid placements, and here's some cash honorarium stuff. Let's go, whatever it is, right? We have some people that clean parks because they want to clean parks, and we have people that make vinyl stickers that we were handing out earlier, and just letting people be people and supporting that, I think, is huge, because there's not a lot of programs where you just show up and get to be yourself, right? A lot of, in my experience and the experience of the people I work with and around, it's I'm gonna show up here and this person's gonna lay out a plan for me, and when I get to this end, it means I'm successful. And my belief and my idea behind the program is that there's no set success. It's not when I reach this goal that I'm doing well. It's the fact that I show up is enough, you know.
Yeah.
That's it.
Yeah.
Yeah, thanks.
Yeah, and I think so the program that we have has the prescriber part, but also the peer support part, also an outreach part, also peer training, and all of that came from people with lived and living experience. And then I think the other thing is that I think a lot of programs do this, but it's not either you're a program manager or you're a peer. It's recognizing that people have all sorts of different skills and lived experiences, and can be in a variety of roles. I said we were going to be short, and then I was I'll just ask some prompting questions. So joint decision making is a big part of our program as well. So what that actually looks like is that we meet as a clinical team, but it includes peers who are working as part of the program, who have been through the health privacy training, who patients are aware are a part of the clinical team. So we meet as a group to work through different situations, often more challenging ones. So for example, a patient recently disclosed to me that, unprompted, that he had been selling some of his Dilaudid, and so that's not something that I as an individual prescriber need to figure out how I'm going to move through that, but we actually work through that together as a group that includes not just registered healthcare professionals, but includes people in that peer support role as well. And that has informed, I don't know, all sorts of things, our intake criteria and our criteria on how we handle missed doses and how we adjust our things as we go along, because we're new, so we're certainly still learning. But we really try to bring that to the group of us together to make those decisions together in terms of how to move forward.
And I think really just quick on that whole thing is also when there's challenges, or we don't all see things the same way or approach things the same way, we discuss it and we go back and we change it. I think there's been a few things that started as part of the beginning policy, for lack of a better term. I guess it's a policy. that we've come back and like been like, okay, well, let's change that. Like
Yeah.
missed doses, I think, has gone different ways
Yeah.
at some point, right? So it's just like everybody's voice has a space, and because the clinical perspective is one perspective, and then like the I hate lived perspective. I don't know what I'm saying. I guess stutter.
Expert perspective.
Expert perspective. Like
Yeah.
it's just different, right? Like what diversion looks like on the clinical side as opposed to, and I don't like the word diversion, but like what it looks like on the other side is totally different, right? Like it's the reasoning and all that stuff. So yeah. So yeah.
This is oregano. This is our joint decision making. Come on, guys.
Like somebody laugh at our slides. What's next? I don't even know. Oh, we're stuck. We're just gonna stare at oregano.
The problem is I don't even remember what the next slide. Oh, there we go.
Different skills and strengths.
Montreal steak spice.
I guess that's me.
you.
All right. This is how we do things. Different skills and strengths. So again, like I think we've already kind of talked about it. Is like everybody has what they bring to the table, right? And that changes. Like and roles change, and obviously doctors are doctors, but like my role has changed, and other peers like have changed and like grown and developed, and it's part of why we offer like peer support. We offer the opportunities we do. Like we have peers with Keeping Six that are now part of the YWCA that Dr. Bodkin mentioned, is like the second only, if I'm wrong, please correct me, someone, after slap me, something, whatever. Second women's only safe use space in Canada. And they came to us and like we partnered kind of thing. And again, like peers are there, right? And we're working towards some shifts being only peers. We're not quite there yet. I still keep pushing that at the end of the day, if shit was going bad in my life, I'd want people that have had shit go bad in their life there, you know? And not that other people don't have shit, everybody has shit, but I think you know what I mean. And we get to be part of that, right? And that place, like one of the directors of the Y said, like this wouldn't exist without these folks, right? Like if there wasn't people with lived experience showing up to work, the work wouldn't look like this.
Yeah, and I think that like from a employer perspective, valuing that people bring different types of expertise and that lived and living experience is expertise, and that it coexists with skills in research, skills in program leadership, skills in coordinating meetings or whatever, is also a part of the different skills and strengths that we all bring to things.
And if I could talk one more time, I ramble, this is what happened, I think I told you.
You're doing
great. My journey, and I'm not going to get into my whole story, but it's messy and like weird. But like even I was talking to someone back at the table for like pathways to recovery about where my journey was, right? I stood outside pharmacies selling drugs and buying pills. It's what I did for years. And today I don't. And I always wondered like what that meant. Like why did this stuff occur? Like what is it ever going to benefit me, right? Like I'm just this person that's been to lots of rehabs and gone through all this stuff. And if you asked me a few years ago if I'd sit at a table with doctors and be in a room with medical people, I'd tell you to go fuck. Sorry for saying it, but go fuck yourself. Honestly, no offense to any physician, but just my journey. We heard earlier, like some people, their medical history and their health journey in life has been kind of shitty, right? And I wouldn't have been there, and today I get to be there, and I'm valued for that, and it means the world, to like feel valued. And we try to do that for the people that access service, right? Just like
friendship, the spice of life.
Best picture ever.
So I do think underpinning this is like we have close relationships, and I think one of the advantages to having started as like a grassroots group is that it's not like we came together because we all happened to get hired. Like we came together because we cared about each other and we cared about our community, and through those relationships we're able to build some work together, and then from there like applied to different funding opportunities and expanded our programming and that sort of thing. But our relationships with each other I think are a huge part of why we work well together as a team. We don't just like see each other at work. We have dance parties together.
They all dance. Those videos.
So this is a picture from when Parkdale Queen West welcomed us to visit their Safe Supply site and program so that we could learn a little bit more about what they were doing before we set up ours. But it's a group that I want to take road trips with, so I think that helps too.
Contrary to like what that picture shows, I'm actually smiling there. Like looking at it. Don't even say it. It's like a really bad face. But yeah, it's again about relationship and community and like getting to know each other and spending time together. And I think that's what this kind of conference, whatever you want to call it, would have been a webinar last year, is what it's about, right? Is like networking, getting to know people and involving people. And I sent in like a crappy resume 2 years ago, right? Like it was bad. Like I think there was like a 10-year gap in work and I just like kind of made some shit up. Cause I'm like, I sold cocaine. Hire me. Isn't like a thing.
I have business management skills.
I could have used that. Yeah. I'm using that next time. But yeah, it's all about the journey and about knowing people and caring about people and not really, like for me, I don't give a shit what people put in their body. I care about, can we do that safely? And I said earlier, talking to someone, like recovery, for lack of a better term, isn't about abstinence. It's about waking up in the morning and being somewhat okay being awake. That's it.
We'll end there. Anyways, yeah, so that's a little bit about our SASS program.
Awesome presentation, guys. I feel like...
Is it that bitch right there?
No, I'm not doing it.
Okay.
Stop it. No, awesome presentation. I know from like Kitchener-Waterloo, we're like 45 minutes away, and you know, just to get to learn a little bit more about the programs, this is what today's is about, so that's really exciting. I also just feel like we make it sound like it's really complicated to make sure people who are using drugs are actually driving our programming, and so to have you guys doing that well, I think there's going to be a lot of good questions afterwards. But yeah, I think London's up next, but I just wanted to check. There is some handouts that they have for their presentation. Did everybody get it?
Nope.
You need one? Okay, we'll get one for you. Don't worry. Okay, so we'll just, I'll kick it over to Sean and Cassidy, and we'll get going on the next one. You're up, guys.
I just said that really loudly.
Howdy. Can everybody hear me okay? Okay, fantastic. First of all, thank you for having us here to the COP and for organizing this event. It's been incredible, and it's really nice to share a room with a bunch of folks that are interested in pointing things in a similar direction and making sure that we can do better for the people in our community. So this is an amazing experience. And also thank you to the two of you for sharing your program. It's really nice to be able to share this session with you, so thank you.
Thank you.
So my name's Sean. I'm a care facilitator at the London InterCommunity Health Center. Essentially case management services for the Safer Opioid Supply Program and folks that are receiving safer opioid supply prescriptions for us. My counterpart, Jessica Manzera, is also in the room as well. Our role within the program is really to facilitate the model of care that we've developed and that we try to facilitate for the folks that we have on the program. So we act as a bit of a go-between between the social aspects of our team and the medical aspects, providing case management services from a social determinants of health lens, as well as advocating with systems and systems partners to try to create an ecosystem and a community that's more conducive to the wellness of the folks that we serve. Cass?
Hi, I am Cassidy Morris. I am Program Administrator at London InterCommunity Health Center for the Safer Opiate Supply Program. I've been doing that about 6 years now since we started. We did want to start off today's presentation just with a quick disclaimer in recognizing that we are facilitating a medicalized model of care. And it's embedded in a medical system that has a long history of oppressive practices towards people who use drugs. So we really do want to acknowledge that. We try to work within that system that already exists to do our best to facilitate around some of those pieces. So the Safer Supply program that we host is within the context of a community healthcare center. And that includes the community healthcare model of care. So this entails the provision of interdisciplinary services for individuals experiencing barriers to healthcare in the community. Specific to our program, the benefit of this model is the vast interdisciplinary services that we host at the center, comprised of all types of different professions. So we have everything from primary care, outreach, dietitians, physio, psychiatry, social work, on-site lab techs, systems navigation, hi Steph, Seniors wraparound, youth outreach, foot care, infectious disease teams, including our My Care team for those with HIV and AIDS, and our hepatitis C care team, community development, trans healthcare, newcomer clinic. It's a big group of people. The strong interdisciplinary setting enables low barrier access to health and social services for folks accessing primary care and obtaining safer supply through us. So our safer supply is offered as part of full interdisciplinary care.
So the Safer Opioid Supply Program model can be seen on one of your handouts here. It's the harm reduction, stabilization, and comprehensive care phases. And to be very clear, none of these stages affect the care or the supports that anybody receives. These are more of a reflective tool for the team to go back and assess and kind of ground ourselves again about what we're doing and where we're supporting individuals. It gives us an opportunity not only to see what resources and supports an individual has, whether that be natural or programmatic resources, but also gives us an opportunity to assess where the systems and partners in our community are at with supporting these individuals, provide advocacy, and hopefully creative problem solving to make things pointed in a bit of a better direction. All of our care is facilitated from a social determinants of health lens, and the vast majority of our care is facilitated within the clinic. Cassidy will speak more to some of the other programs that we have that go outside of the clinic, but the clinic space is a really vibrant spot at the health center. We see sometimes upwards of 70 patients a day, participants a day, clients a day, whichever language you prefer. And this is a great space for engagement. So everybody comes in to facilitate not only a check-in, but it's a chance for them to build rapport with their team as well as engage with the social and medical aspects of the program. Again, we do offer full primary care, but the full suite of social services that we offer along with that helps build rapport with the center as a whole. I can count on the team to bring to me anything that's coming up in a nursing check-in, for instance. That might be something that I can engage with around housing, criminal justice system support, income support, whatever it may be. And in that way, we have a really high level of engagement through the center doors on a daily basis.
Yeah, so you will have a handout of our typical clinical flow for an SOS check-in, as we tend to call it. It's laid out in a way that allows the clients to touch base with multiple staff members and roles in hopes to identify and address both medical and social needs efficiently and in the moment. So the clinical team, which is usually consisting of our lab techs, then to our RNs, and then NP and MD if need be, all work in unison and consistent communication to help navigate clients appropriately through their appointment. So we work with clients to not only complete their SOS check-in, but giving them the opportunity to address the full scope of their medical or social needs. This can include primary care or chronic health concerns, acute medical issues that may have come up since we last saw them, access to our infectious disease teams and mental health teams as needed, and all in addition to obtaining their safer supply.
So we've been given the task of trying to name what the culture that we have as a work family is. And it's really weird to try to name the components of something that you live on a daily basis, especially I'm not sure if anybody else has shared this experience during the COVID-19 pandemic, sharing the same closed space on a daily basis, and that being really your only social interaction outside of your house. If you had any great privilege to be able to do that, but also we developed a really close-knit group of workers. So when we tried to name the culture that we have, we were able to distill it into a few components. We hope we did a good job of it, but communication, respect, trust, a willingness to approach challenges, and leadership are really some of the things that seem to permeate the team that we have and make us tick. The communication aspect of things is incredibly important. As I was mentioning, when folks are coming through the door, they have so many touch points within the clinic between the clinical teams and the social teams that I can always count on the team to bring back to me concerns that are best suited by myself or another aspect of the team, and I can also provide that reciprocity to individuals. Assertive engagement is something that's also super important to our team. We're a team of doers, passionate doers, and sometimes to a fault. So if there's ever something that's coming up on a daily, if there's ever something that's coming up within the day-to-day that's better suited to another member of the team, I can count on that individual to take that off of my plate, and vice versa. We're really good at saying, let me help you with that whenever it's most appropriate.
Absolutely.
When we talk about the trust and respect that we have for one another as well, it's the trust that when we provide tasks or we make an ask of somebody that they have the competency to do their job well, we know that task is going to get done. And if they do need support, we can also trust our team members to reach out. That communication, trust, and respect also kind of permeates towards the end of the day. We all do very difficult work. I want to say sometimes, but it's all the time. And we can also count on our team members to provide us that space, whether it's during the day, end of day, even sometimes after hours, depending, to provide that space to one another to really relate and try to make sure that we're always grounded and well in the work that we're doing.
Yeah. I always say that our secret sauce is really the team, the friendships and weird oddball little family that we've become over the years. We all work together so condusively and with just such probably what many would consider over communication, but we're all always focused towards client goals as they identify. We try to keep it client-centered, client-focused, and just go along that journey with them, whatever that looks like. And we pull in different team members when and where needed and support one another all along the way. Like Sean was speaking, like, I don't know how many times we will, during lunch, being like, okay, we need to like debrief, or like, let's talk this out, or after hours, like, it never stops, but in the best way possible, because we just have such a great team of humans that work together in order to support our folks.
One of the key things is that we work as a health center towards we have a North Star. We're always aware of our strategy and where we want things to lead us. A key part of that strategy is working with systems partners, and that's just not the partners that are willing allies and are already aligned. If anything, it's more important to draw on those partners that present challenges. We're trying to create an ecosystem, a community that's conducive to the wellness of all folks, and we all know that we run into those roadblocks from time to time. So a key aspect of that strategy is making sure that we're working with a team. And sometimes there's individuals within those larger systems, agencies, services that are allies, or people that are at least willing to learn. And what we typically find is we find those individuals, and we're able to build those relationships and able to work up within those systems. Taking the top-down approach, we know, as we do in a lot of aspects of our work, is time-consuming, and oftentimes you can hit these roadblocks very quickly. But going from the bottom up and really working with the folks that are providing that direct service, showing that this is the way forward for the folks in our community, we find to be one of the most fruitful strategies that we can implement in the community. We also implement that internally as well. When we're trying to provide programmatic change, we work with the folks that we serve. That is the absolute most important thing for us. We do have a peer advisory group. COVID obviously put a bit of a wrench in that plan. However, we are starting that up again, and that advisory committee is able to come together to bring together more of the larger programmatic aspects of things, talk about how we can change the program center services as a whole, but also in the daily visits with the folks that are coming through the clinic doors, there's this aspect of co-design. Everything's client-directed and client-led, and when we're trying to develop a plan with an individual on a day-to-day basis, it usually presents opportunities to implement larger change throughout the program and throughout the center, and we're very vocal about that, and we share that with our clients as well, and make sure that we're involving them in that process and seeking permission to try to bring those changes out to the other folks that we serve.
So one of the pieces of partnership that's manifested and created systems change is our health outreach mobile engagement, or our BUS, we call HOME, home. It was a partnership between outreach, health emergency services, and community sites that's flipped that ideation of hard to reach patients into hard to reach doctors, and we've tried to see some capacity to address that. So we bring interdisciplinary services out into community, into the homes of clients, into encampments, into shelter, wherever folks may be, in order to provide those primary care services, acute medical care services, safer opiate supply, wound care, social supports, the whole kit and caboodle. And we've had really incredible outcomes doing that.
Again, at the center of all that we do, it's the folks that we serve and the community that we serve. Sharing a great story about how our clients in our community are driving change. A few weeks ago, there was a public health advisory that was issued for a substance that was virtually identical to crystal and was 70% fentanyl. So the community took it upon themselves to bring that substance to the services that were able to get the checking done, but also took it upon themselves to educate their other community members and get the substance off the street. Talk about great community communication as part of the team. The community is the team, and that's something that we really try to orient ourselves around. That was a key aspect of getting any of this done, was the transparency and the rapport we have with our community to bring these concerns to light, get it out to the public health agency that's local, and also for the folks on the street to get things out of the hands of those that were most in danger by it.
Yeah, it was amazing to watch. So all of this to say, because we've kind of rambled, our team prioritizes some familial values in respect, trust, and communication. I think those are the most key things to any team, any practice, really. So this supports the creation of a culture where team members seek to support one another in the work towards client goals, where we remain centered on those client goals, where we provide space for one another to challenge systems, services, and have individuals grow. Thank you for letting us talk at you for a few minutes, and I will pass it back over to Kourteney to see if there's any questions or any chats we want to have further.
Awesome, guys, thank you. I know being outside of an urban setting and being a standalone safe supply program in a smaller city, it's been great to have you guys down the road to look to and model after, but yeah, so thank you guys, and we'll open it up for questions. There's the mic in the middle, so if anyone wants to get us going, feel free.
I don't know if that's good
Questions?
I was expecting
Anybody?
big, scary questions.
There you go,
Oh,
Michael.
cool.
Michael
Thank you.
Parkinson, Region Waterloo.
Thank you. It's got awkward.
Someone's got to do it. So you talked a little bit about challenging services and systems and structures, that kind of thing. What does that look like on the ground in terms? Well, what does that look like on the ground? Who's around the table and doing those kinds of activities? And then, if there was a follow-up question, it would be, how safe is it in your community to do that kind of stuff? Because it gets pretty local, right? And sometimes those are your funders.
I'm going to be very careful in what I say because both our manager and our executive director are sitting in this room right now.
I hear they're great.
They are pretty great. No, and
greatest.
they are the best because they've really given us the trust and respect to allow us to do what we do and know that we are going to do what is in the best interest of the clients, but also the health center and the team as a whole. So we do a lot of systems advocacy on all different types of levels, at all different types of tables, right? So everything from criminal justice system advocacy. Jess plays a huge part in that, working with the local prisons, EMDC, which is a big one for us, coordinating care for folks that are going in while they're there and coming out, to maintain either safer supply scripts or that transition pieces. Housing is always a big one. We know what the housing market is like, though, so we do have not only our case facilitators, but a full team of outreach workers that also do a lot of housing advocacy pieces. Hospital care, I will let Sean speak to because he has been an absolute rock star over the past few months working with the local hospitals in London, just with the ethics committee and having some of those like kind of challenging conversations surrounding language and practices that I think of starting to finally make a really big change within the city. That's been really cool to see. Family services was also a big one, working with Children's Aid Societies. We have, some more templates and letters, and we've been having a lot of table discussions with them, all of which I need to completely give all these shout outs to Stephanie McCall, our systems navigator, Jess and Sean, our case facilitators, because those three really take on a lot of those pieces and put in a lot of work surrounding that. I will let you talk to that more if you'd like.
Yeah, I think speaking to the safety aspect of it, because I
Yeah.
think that's a really important question.
Definitely.
Not always, but internally, yes, our leadership does a really good job of creating safety for us to do what we feel is the right thing. I think staying value-centered and making sure that we're, again, oriented towards that kind of North Star of value in the people that we serve and the community that we serve feels inherently safe because it feels that we're doing the right thing, and we're afforded that bandwidth by the leadership that we have. Speaking to the hospital work that I've been doing, I think something that I found really helpful, and there's no right way to do it, it always seems to be you find a relationship and some of it goes somewhere and some of it doesn't. Finding individuals, like we were talking about the ethics and equity departments within the hospital, folks with both upward mobility in the hospital to the leadership teams, but also mobility to the bedside teams as well, has proven to be really effective. So we've been able to do some translation literally of the language that's in the community versus the language that's in those larger institutions, try to develop a shared language and then move forward with those values. We like to believe and we like to think that everyone's working towards the same goals and shares the same values of wellness, right, for the community. And again, keeping oriented towards that North Star is really important. So establishing those shared values, establishing a language that you can both speak and understand what's going on, and then keeping things oriented towards the client and the community.
Absolutely.
I think.
Yeah, go ahead. No, I was just going to say, do you want to touch on the Hamilton perspective?
Yeah. I'm going to try not to go on like a huge rant.
I'll go.
So, I'll go. I think for me personally, I understand like the safety, especially I think you mentioned like funders, right? Like sometimes you're funded by a city. We luckily, don't have money from the city. I don't think. As far as I know, we're not funded by the city. A couple years ago, I don't know if anybody follows Hamilton news, there was an injunction around encampments in Hamilton, Ontario for, I think, it lasted 3 months. And we took the city to court, and on behalf of people outside and behalf of the people we serve. And it didn't like last forever, but there was 3 months where like encampments couldn't be moved, right? And in that time, people got a chance to look at their lives. Like, I don't know if anybody here has like lived outside. I have. It's not great. But when you live like in that life, right, and in an encampment, and you know when you put a tent up, it's going to come down. You have no real chance. And it's either going to come down by like peers getting robbed, fires, police, something, right, that doesn't like you or doesn't want you where you are. Which happens in houses too, but it's a lot easier just to get rid of a tent than it is a house. But you don't get a chance to look at your life, right? And we've seen that with people. They're just like uprooted. And when the injunction was in, people got to look at like where they were at, and more people accessed services, and more people connected, and some of those people are still connected and some aren't. Now it's kind of gone to shit over there. Like now it's like 12 hours after there's a complaint, tents come down. So I don't say it was totally successful, but there was good moments. I sit on tables at the hospital, and I'm not one to like sit at shit that goes nowhere, or tables, sorry, not shit. I was part of the encampment response team with the city. I sat at that table for 4 months, and I sat there till I couldn't. And that's what it is for me. Like, I will sit at any table. I think everybody deserves a voice. Everybody's voice means something and has value and holds weight, whether they agree with me or not. I'm not a big person on fighting. I think dialogue gets us farther than disagreement. But sometimes there's a point where you just have to get up and walk. And like I sit at hospital tables, and I have the honor and privilege of doing that. And again, I'm a person that's been hospitalized like lots and lots of times in my life, and I hate the institution of healthcare for a great number of reasons. But I love it now because I love being able to like challenge that. And I'll sit at tables with directors of hospitals and be like, why are we talking about this if you're literally going to do nothing? I had a conversation recently. I sat at a table for numerous times last year about substance use policy at the hospital, and one of the directors came back and she's like, we're not going to look at this. And I'm like, so what did we just waste our time doing? Right? Like, why, like, we're just going to start over. We're going to go back to the beginning and hit a wall and go back to the beginning. And I think it's more important to start taking walls down than to rebound off them and start again.
Yep. Sean, what you said about working with partners who are, or like finding the people already doing the work really resonated. Like, I think the reason that we're partnered with the AIDS Network and we've partnered with YWCA is because they have shown that they are committed to doing this work and learning, and it like we all have a finite amount of time and resources, so working with the people who want to change things rather than trying to convince other people has just been like a better use of our time, I think, and has accomplished more. And then the other thing I think that's important for us here who work in institutions is, I think this is where grassroots community organizing is so important, because like when we're working in institutions or organizations, then we do worry about maybe like our paycheck or our institutional reputation or whatever. But when we work organizing as part of communities and as part of like grassroots groups that aren't beholden to funders or like trying to get elected or whatever the case may be, I think we have an opportunity there to challenge systems and like really orient ourselves to the work that's important, and to remind ourselves Nanki Ray, who is here somewhere today, often has talked about like distinguishing safety from comfort, and that actually, like if I was to lose my job for some reason, as a physician, I have the privilege of having a license and being able to do other things. I have, you know, other family members that are financially, like I'm from an upper middle class background. I'm not going to be deprived of housing if I lose my job, for example. So I might feel uncomfortable, but I'm not actually unsafe in a lot of the work that I do. And I think that it is like community organizing that helps to ground people, me for sure, in remembering like what's important, what's unsafe versus what's just uncomfortable, and then also like provide the sort of courage to head in the right direction. So yeah.
Just want to add one more
Yeah, go for it.
thing. You kind of hit on a touch point for a meeting that we had last week where we were talking about risk, especially in large institutions, and most of it's framed around how the people accessing a service provide risk to the organization, but really what a privileged space to be. So who is the risk to by shutting the doors and making things tighter? So thanks for touching on that.
Yeah.
Did that answer the question?
Thanks for the question,
Thanks
Michael.
for getting us started, Michael.
Anybody else with a question?
I just had a question for Sean. I was talking earlier with my supervisor about something where institutional keeps coming up, and it's like bouncing off my head. But a while back, I got like an illness that is not really highly spoken of a lot, but it can be transmitted through, say, like unsafe, like injection, or so much as touch, like through your nasal. It's like it's a MRSA. I forget the name of it, and like the full name is like crazy long. But yeah, I got really sick from it one year, and I almost died. I'm not even supposed to be really alive right now. They gave me like a 0% chance. They told me to call my parents and say my goodbyes and stuff. And I was just kind of curious as to, like, PRHC didn't have a lot to offer except for a toe tag pretty much and a phone call. So, and I was just kind of wondering, like, if there was like anything that you would have to offer about that, like what kind of information or anything, just because like you don't really hear much of it. So I was just kind of wondering, like, if anybody has done any kind of like research, or like if you have any kind of information to offer on something like that.
I actually am not sure I'd be the best one to answer that, Claire. I'm wondering if you might have more information. Is that okay if I ask the question? Thank you.
So without knowing all of the specifics, I think one of the things that can be really dangerous about MRSA infection is when it gets into your blood or gets into your heart. And so I guess it depends on what you, I guess I would say that I'm stumbling because I don't know that I know exactly what the question is. I'm totally happy to chat.
I was just gonna say maybe we can just at the end connect you guys.
Yeah,
and we can
I
have
would
a
be happy
conversation
to
a little more.
like chat at the end about specifics, and then I guess more broadly, like I think that the things that come up for me at least are that we need safe injection spaces and safe drug use spaces in hospitals to help people be able to use safely when they're getting hospital care, making sure that people have access to harm reduction supplies in hospitals so that they can get like new needles and new pipes and that sort of thing. And then to plug Hamilton again, there's a neat group doing something called Second Heart, which is around supporting people with, actually, Marcy, you're a part of that team, supporting people with infective endocarditis related, or like heart infections related to their substance use after they leave hospital, so that people can still be connected to family medicine and healthcare. So those are the things that come to mind, like broadly around MRSA infections, but I am super happy to chat one-on-one as well about more specifics.
Okay,
And
thank you.
one thing you said, and I don't know, I don't want to like misread what you were saying, but the idea where it's not really talked about, right? Like,
Yeah, like
there's so
when
many
I got MRSA, I didn't even know what I had until they told me. I'm like, what the hell is MRSA? And then they're telling me, like, I'm gonna lose my arm if I don't hurry up. And I was misdiagnosed 3 times as a junkie, and they told me that if I had, I'm like, so if they rushed in, they told me you have to be moved immediately, and they were still saying that because it's institutionally like transferred, like from hospitals, jails, grocery markets, like big places like that. But they were trying to like insinuate like I got this like strictly from like intravenous use, but I was actually hit by a truck. And I was just wondering like what kind of like, you know what I mean, like where to pinpoint like information, because like nobody really knew anything, and it was like taken in by like the news and stuff like that, and I didn't really know what to do, and nobody really did. I didn't get any information, and I was just kind of hoping like somebody would be able to like help narrow it down kind of deal.
So ironically, MRSA is one of the most commonly transmitted infectious diseases that is caught in hospital.
It is, right?
It is.
Yeah, that's what I thought.
Yeah.
They were denying all that too. So
I think it goes to stigma, right?
Yeah,
Yes.
absolutely.
I would very much write that up to
It
stigma.
goes down to stigma. Like once medical records, medical history, and this is a debate I have. Oh, sorry. It's a debate I have or discussion I have all the time with like at hospital tables and at community tables and any place that like a person before they meet the patient or the client or whatever, they see their record, right? And as soon as it says like substance user or
yeah, as soon as they're
addict or whatever,
flagged.
that change, and it shouldn't, but I think in a lot of instances, I'm not gonna speak everywhere, but it changes how it's approached,
Yeah.
right? Like I just had, as part of the Second Heart thing, and a client, like someone I know, their partner's in the hospital, and they wanted to leave a message, and the nurse is like, we don't give messages to people. This like happened yesterday. And if it was someone else phoning for like their grandma or their sister or their cousin, I'm sure the nurse wouldn't have said that, right? Like, and it's, I think a big part and a big thing that would help, and I'm not necessarily just your situation, but any situations, is education, right? And conversation, and having these conversations in like more community settings, right? Like we do community events as part of our thing where we have like art and music and poetry and food and people talking about endocarditis or whatever, right? Like, and just putting a face and putting like humanity before like a chart, you know?
I guess then like if I were to like my main question, if I were to just like narrow it down, is there like anything like specific like endocarditis, and then there's like a big read up on it and like about it? Is there anything to do with like
I wonder
MRSA
if it might be better
well?
to just, I think that we'll connect you and Claire at the end, and we can have that conversation. Like, thank you so much for stepping up and asking the question and sharing. But it might be better for like an intimate conversation, and we could probably get you a little bit more information.
Okay. Thank you.
Awesome though, thank you.
Thank you.
Anybody else with questions? We got about 10 minutes left. Oh yeah, great. Oh, it's just the mic. Yeah, the mic doesn't move.
The mic doesn't move.
No, it's,
Can it lean forward? Okay, sounds great.
Look at that.
Hi, as some people here already know, tomorrow my daughter and I are spreading the ashes of somebody who's one of the statistics in Windsor. He died in November. I'd like to see more communication on how we can support less deaths like my son's. My son died of a fentanyl overdose. I'd like to see communication on how we can support safer supply, support for people who need the support or hopefully till they can take better care of themselves, in my opinion. Like, I might be using the wrong language, but I'm a mom that's going through one of the hardest things I'll ever have to go through.
yeah.
I just want to see how I can support. I've always, as I've learned, tried to keep space for people, treat them or not, but I want to know how the wider community can do more to help people when they're vulnerable. Like,
yeah, absolutely. I'm so.
I figure this is a safe place to share. The coroner told me my son died of 5 times the lethal dose. I believe that someone who wanted to pull him back into the community the drug community had left, did that on purpose to send a message. That's what I've heard from the people who knew him in Windsor's last days.
Yeah.
I want to know how I could, what those of us who aren't in this community, who are parents and other support, who support healthier, what we can do to get the general community more supportive of helping people feel better.
Absolutely. I think we can always work to do a better job on that, and I'm incredibly sorry for your loss. I think
I don't want more losses. Like, I want to do what I can to stop other moms from going through getting phone calls like the one I got in November.
There is a group,
I was gonna say, yeah.
Moms Stop the Harm, which is mothers and parents. I believe there's a couple of gentlemen that I've met on there, that kind of do that stuff, right? They get involved and educate. And I think just speaking up like this, like I'm not going to sit here and pretend I know what you've gone through. I've lost lots of people I care about, but I've not lost a child to this. I've not, you know what I mean? And I
I don't want
appreciate
anybody to go through what we're going through.
Yeah, nobody knows, right? Like grief is different for everybody, but
Yeah.
the idea of education and the idea of like community and saying like this is enough.
Does anybody else want to connect?
Thank you. Thank you.
Thank you for your
I do think, like, I've had the privilege of taking care of some folks. Like, part of my work is as an inpatient addictions medicine doctor, who have ended up in hospital quite sick, like either after an overdose or with an infection. And it's always so, like, I feel like the people that I get to offer care to are always so incredibly appreciative when they have a family member who stays connected with them and isn't judging them for their substance use and is showing up for them. And it doesn't mean like not having boundaries or not being able to take care of yourself, but it means that you are doing your best to show that unconditional love and show up for that person wherever they're at or whatever is going on in their life. So yeah, that's something that seems to be really powerful that I get to see in my work sometimes.
There definitely needs to be more for like the people, outside people affected by all of it, right? Like,
Yeah, absolutely.
yeah.
And I think that's like a really good conversation to bring up here is like we're here as a community of practice, and how do we better support some of those conversations? And I think there's a ton of great resources here, and maybe there's an opportunity to have a conversation and see what might be available locally as well. So maybe we can touch base after. Any questions?
Yeah, well, just really more some comments. I just want to say that this whole conference has been fantastic, but this particular portion has got me more excited and motivated.
Can you?
More excited and motivated than
Perfect,
any
thank
other
you.
portion of the conference. Like I'm just, we have some really strong foundations and things going on in Ottawa with our community health center, but I just really like the presentation and how the bigger picture is really outlined in clear as day. And it's really exciting to see that. It's motivating, and I hope that things can move forward because it's, you know, it's past time where people have to realize that, you know, whatever everybody's been doing hasn't been working.
Yeah.
And I'm just amazed at your team and everything that you're doing. And I did have a question about your name, the London InterCommunity Healthcare Center. So what, like, Greater London? I'm not sure.
It is London specific.
InterCommunity.
Oh, sorry. It is London specific, but we do host the national community of practice, so we do have that bandwidth to also support outside of the community in some ways as well, do some education and skill building, capacity building, or just participating in conversations. We're always open to all of that, but the instrumental services, like the care that we offer, is London specific.
Okay. And yeah, no, it's great. And my supervisor at the Oasis program in Ottawa, when I was asking if I could share some substance use, work-related substance use policies with some organizations that are doing research and lived experience interviews and stuff like that, and he says, yeah. He said, share generously and steal shamelessly. So I'm going to try to plagiarize the hell out of you guys.
Nice. Yes.
Thank you.
Definitely. Absolutely. Thank you. I think just if anybody doesn't have another question, I was just going to throw it to you guys. If you were sharing some wisdom to folks who are starting out a new program, I think like we often talk about culture and you know, think about the way we need to reflect in our practice, but like more operationally, like how do you guys make that function if you were giving advice to a new team coming on?
So it's constant just adapting and changing to fit the needs of the community, right? Like where we were in 2016 is completely different from where we were in 2019, and it's completely different from where we are today, and I'm sure it'll be different in another year. It's that constant of just reassessing program needs and client needs and adjusting our practices to them so that we can just continue to evolve and grow. And it's just a lot of creative brainstorming and late nights and just trying to fill whatever gaps we can in a really shitty system.
Like from an interdisciplinary team sense,
Yeah.
like how are you guys making sure voices are centered? Like what is the strategy you would offer there?
So we have a lot of client conferences that involve our clients. I think that's a really good place to start, is just we sit down as a care team that involves them. We're not going to sit around and tell them what we think they should do or what we think is best. Just involving them in their own journey, in their own care, I think is a really great starting point.
And making sure as many members of the team from different disciplines are at the table as possible as well, because they all play off of one another.
Yep.
And it might seem like something is a bit of an outlier, but ensuring that everybody's at the table all of the time, participating in those conversations, even if it's just to be present and see how the group works and, you know, keep that muscle flexed. I think that's really important as well.
Yeah.
And also making sure that we're sometimes it's a very Western way of doing things, that we put policy and procedure ahead of action.
Yep.
And we're catching up now. The community's known what it's needed. We're catching up. We're decades behind.
Yeah.
And I think that sometimes we prioritize that policy and procedure, and absolutely sometimes it's needed for safety, but I think that we need to be quicker to respond.
Yeah.
Great,
Yeah.
awesome. You guys want to share?
I'm not sure like the right way to answer the question. I think for me, like starting out or even like day to day, realizing like the value of my own experience, but taking into context that my experience isn't everybody's experience, right? And I don't know what's gonna work and what's right and what's wrong, and just being willing to like fail, for lack of a better term, right?
Trial and error. For sure.
And just showing up is like the biggest thing. Showing up and speaking up and admitting when I don't know, and letting other people speak, right? Like I think so many times we're taught in life, and not just in this context, but in all contexts, to be right? And to like put ourselves first and all this shit. And really some of the biggest lessons I've learned in my life are the times I was wrong. And I just want to give a shout out. I didn't think I was gonna do this, and it might be inappropriate, but I'm from the city of Ottawa. I was actually asked to leave. My other option was prison. And I went to all the community health centers for various things and lied my way into obtaining what I needed. And I love hearing that things are going well, and that the people that I've lost in that city weren't lost in vain.
Yeah, thank you.
I think there was a question in the front.
Yeah, I think Claire's just gonna answer.
Is it okay if I'm going to say one other thing about this, and then we'll take your question? Is that okay? Yeah. Okay. A couple of practical things. So one is like, I don't think we're doing it exactly right. Like we are going through some big growing pains as we get bigger and bigger. And Tara, our outreach coordinator, is here, and like I think in some ways has had to suffer through the like going from small to medium size and what it means, and like us figuring out our communication. So we've like really basic things, like we've just like started doing monthly staff meetings and like stuff that sounds really basic. I do think one thing that's important to think about when we talk about like finding people that you get along with and that you can build a team with is that sometimes that breeds homogeneity, or like everybody looking the same, because you end up and being the same, because you end up hiring people that you already know or that you're already friends with, or like you find a connection with somebody because you've shared a similar life experience with them. So something that we're trying to figure out at HAMSMaRT is how to articulate what our values are, so that those can go into place for things like hiring and decision making, but then also alongside that figuring out what it looks like to have equitable hiring practices, so that people are coming on board from like a variety of communities and identities and skill sets and backgrounds, that there's like an equitable hiring process, that there's support for people when they come on board, that people are being paid equitably, that we're like naming how racism operates and how colonization operates, and how we can like try to work in anti-racist and anti-colonial ways. We definitely don't have it figured out, so I'm not suggesting that, but just to say that like I do think that that is an important part of operationalizing the work that we do and the teams that we're building. Yeah, I will leave it there.
No,
and
that's
then
awesome.
Gabriela.
Yeah, just conscious of time, we'll do this question and then you guys can have your break.
It's probably going to be a long.
Open it up.
I just want to know, because I work at a community health center, and in our center, we only offer OAT. And I really wish, like I've suggested and I've asked about offering safe supply as well.
Yeah.
Because, safe supply needs to go further than it is right now.
Yeah.
But it's a good start to offer more options. How did you get it into your center?
So,
Where is she? Where is she?
this is actually a funny story that I was talking about at lunch with our executive director. Dr. Sarita just started kind of doing it. We started with 3 patients that we were working with. We were really heavily involved in the Street Level Women at Risk program in London for street level sex work. And we had so many of our girls were really high risk, in and out of hospital. And as Dr. Sarita was saying in her welcoming speech, she just wrote that first prescription, continued that hospital discharge medication prescription, and it worked. And so we added a couple more, and then we added a couple more. And it was, I don't even think, it was probably almost like a year in before we really even knew what we were doing. We were just sort of doing it. It was much like my coworker Sean was saying about action first, policy and process later. Like, we just needed to do something to save people in that moment, because it was 2016, fentanyl had hit the streets in London. We were losing like 11 people a week, and we just could not bear to sit there and do nothing. So we just started prescribing, and we added people slowly but surely, and before we even knew what we had a safe supply program. Before we had a name for it. And then eventually we went to Scott and was like, hey, by the way, we've been kind of doing this thing and it's starting to get big now, so like you should know about it. And Scott, bless his heart, always has our back, and eventually went to our board and smoothed that over. And I'm gonna be very careful how I word this, but I think how we were able to do it is we just sort of did it. We just said, screw it, and we did it, because otherwise people we knew and loved were gonna die. And so we saw the need, we filled a need, we adapted to the needs of the community, and that's what we've just continued to do, and hopefully we can expand not just safer opiates, stimulants, et cetera, et cetera, et cetera, all of the needs that are out there. I hope that answers your question.
It's a tough one. I think a great strategy is just if people are willing, if the conversations are happening, but someone's not willing to take that stride. I think the consultation line is a really great starting point for folks, as well as a national community practice. If you can get somebody in that space, I feel like there's a lot of opportunity and a window there to have those conversations and kind of demystify what we're doing.
Yeah.
But yeah, anyways, thank you guys for the session. Thank you, panelists. Have a good afternoon.